Systemic treatment of thyroid cancer, the 2026 ASCO Guideline. Welcome back to the Head and Neck Oncology Journal Club. I'm your host, and this is episode 16. This week, we are covering a new ASCO clinical practice guideline published in the Journal of Clinical Oncology on the systemic treatment of thyroid cancer. Nabil Sabah, Beth Beadle, and a multidisciplinary expert panel pulled together the evidence for drug therapy across all four major thyroid cancer types. Thyroid cancer is really several diseases under one name. Most differentiated thyroid cancer is indolent and does well with surgery and radioactive iodine. But a subset becomes radioactive iodine refractory and progressive, and medullary and anaplastic cancers behave aggressively from the start. Over the last decade, multi-kinase inhibitors, targeted agents against BRAF, RET, and NTRK, and selective immunotherapy have changed the landscape. And clinicians have been left with real questions about which drug, in which order. This guideline sets out to answer them. The panel asked 4 questions for each tumor type. What is the role of multi-kinase inhibitors? What's the role of genomically targeted therapies? What's the role of immunotherapy? And what's the role of cytotoxic chemotherapy? First line and in the latter lines. The literature search ran from 2000 to November 2025, screened over 1,100 articles, and 66 of them formed the evidence base. Every recommendation carries a grade evidence rating and a strength rating. On public comment, 98% of responses agreed with the draft recommendations. The single most important theme, molecular testing, belongs at the front of the pathway. If a tumor carries an actionable driver, targeted therapy is generally preferred over a multi-kinase inhibitor. Now let's see what's the scene in well-differentiated thyroid cancers. Starting with that, the papillary, follicular, and oncocytic types. Surgery and radioactive iodine remain primary treatment. Systemic therapy is for radioactive iodine refractory, recurrent, or metastatic disease. With no actionable driver, first line is lenvatinib or sorafenib, with lenvatinib generally preferred. That sits on strong, high-quality evidence. In the SELECT trial, lenvatinib extended median progression-free survival of 18.3 months versus 3.6 months with placebo. After progression on a multi-kinase inhibitor, cabozantinib is recommended on the back of COSMIC 311 trial, and when a driver is present, targeted therapy comes first. An NTRK or RET inhibitor before multi-kinase inhibitors for fusion-positive disease, and dabrafenib or trametinib as an option for BRAF V600E. Immunotherapy and chemotherapy are not recommended first line outside a trial. Now coming to high-grade and poorly differentiated thyroid cancers. This group is harder. The evidence is thin and largely extrapolated from the subgroups in other trials. Lenvatinib or sorafenib may be offered first line. Targeted therapy may be offered if there is an actionable alteration, and immunotherapy may be considered. But the panel could not make a strong recommendation in either direction. Anaplastic cancer is an emergency. The workup needs to be swift, including airway management and early BRAF V600 testing, because that result changes everything. For BRAF V600E mutated anaplastic thyroid cancer, dabrafenib plus trametinib is recommended first line, and pembrolizumab may be added. For disease without a driver, lenvatinib may be offered with pembrolizumab as an option, or dual checkpoint blockade with ipilimumab plus nivolumab. Whatever the systemic plan, controlling the primary tumor and the airway is the immediate priority. For medullary cancer, RET status splits the pathway. For RET mutant disease, selpercatinib is the first line. on strong high-quality evidence from Libretto 531, which compared selpercatinib not against placebo but against physician's choice of cabozantinib or vandatinib, and still showed a clear progression-free survival advantage. For RET wild type disease, cabozantinib or vandatinib is recommended. Immunotherapy and first-line chemotherapy are not recommended outside a trial. A few caveats. For high-grade, poorly differentiated and anaplastic groups, many recommendations rest on extrapolation rather than dedicated trials. The high-grade category was only formalized in 2022 WHO classification, so older trials barely capture it. Several landmark trials predate current radioiodine refractory definitions and modern molecular testing. And head-to-head comparisons between agents, lenvatinib versus sorafenib, for instance, are largely missing. So here's the bottom line. Test for actionable drivers early and let molecular status steer the first-line choice. Targeted therapy for BRAF V600E, RET or NTRK alterations, multikinase inhibitors for driver-negative disease. Selpercatinib is the first line for RET mutant medullary cancer. Dabrafenib plus trametinib for BRAF V600E anaplastic cancer. Immunotherapy and cytotoxic chemotherapy stay largely reserved for clinical trials or later lines. That is episode 16. See you next week. Thank you.